This program is brought to you by Emory University.
I just wanted to introduce our speaker today, John Larson, who is an Emory Med School grad, a Michigan resident, and then we were lucky to get him back here at Emory for fellowship, and he will be pursuing EP next year, which we're really excited about, and we are excited for his talk today. Take it away, John.
All right, thank you, Dr. Coley. I'm going first for the season, so thankfully setting a low bar for the rest of the fellows following after me. But my talk today is about mitral annular disjunction and associated arrhythmias. So with that, let's get started. So here are my learning objectives: to discuss the characteristics of MAD and its common clinical associations, to identify high-risk phenotypes and indicators of ventricular arrhythmias in patients with MAD, and to try to identify data-driven clinical management. And forward hint here, there's not a lot for patients with newly diagnosed MAD. So with that, as always, let's start with a case. So Miss S is a 46-year-old female, and she has this questionable history of WPW, atrial fibrillation, and atrial flutter. Essentially, since she was 19, she's been seeing multiple different cardiologists outside of Savannah, Georgia. She tells us that there have been multiple times in the past when people have a different cardiologist, including EPs, have approached her and said, hey, we need to kind of figure this out through an EP study. We don't really know what's going on with your arrhythmias. But she has been very, very concerned about undergoing procedures. So she has refused to do any of those procedures, instead opting for attempting medical management throughout this. So throughout her course, she has been on beta blockers, off and on amiodarone, and currently on flecainide monotherapy. Now, when she arrived to us, we didn't really have any prior EKGs, telemetry strips, monitors that really showed us what the characteristics of her previous arrhythmias were. All we know is that they would accelerate up to the 180s and that they've all been narrow in the past. So she's now transferred to our care because she presented to an outside ED with wide complex tachycardia requiring cardioversion in the ED. She had never had wide complex arrhythmias in the past, and this was something that was completely new for her. Throughout this course, she was also found to have a reduced EF to 30%. So interestingly enough, she was actually transferred and arrived to Midtown with a life vest on. So she was kind of given that as a protective precaution and was transferred to our care. So this was her admission EKG. You can kind of see the right bundle here, but otherwise not entirely remarkable. That has some interesting T-wave abnormalities here that we can see, but certainly not in an arrhythmia at this point. Just looks like maybe sinus arrhythmia, that she is having no current symptoms. So she did get an echo, of course, and I'll let this play through a couple of times. So that was really her echo. So I'll kind of read the report here. Though, I could have put more in there, but I thought those were kind of the best visualization of what we're seeing. So EF 35%, which is pretty consistent with what we saw before in the reports from the outside hospital. They're calling reduced RV function as well, with some increased right atrial pressure seen. Interesting thing here is that the mitral structure is normal, no restricted motion, no regurg. Valve tricuspid is normal, no restricted motion, no regurg. And then the only thing other that's not notable in this kind of summation report is that there was a dilated right atrium, as you can kind of see, here in this picture or in this video. So solidly dilated right atrium there. So because of this, she was actually taken to the EP lab for an EP study. So after long discussion with her and kind of where we are now, given she had received shocks, which she had never received before, she was now amenable to undergoing an EP study. So, with the discussion of a possible ablation, depending on what we find, given this history of WPW and this history of atrial flutter. So this is actually how she arrived to the EP lab. So if you kind of notice, and I'll talk about this on a little bit, this is not what she had arrived to our floor with. She is now more tachycardic and had kind of been going in and out of this since the morning of her EP study. So as we can kind of see here, there still looks to be pretty clear P waves in here, but kind of been accelerating up into the 150s and kind of bouncing around since that time. So throughout her course, even before the catheters were placed, she switched from that prior rhythm right here into this rhythm, which really looked like 2-to-1 typical flutter, which we had not seen before. So this had kind of just reared its head during the EP study itself. And then we saw this. So we see that she goes kind of in, she's in 3-to-1, 2-to-1 flutter. So, kind of flutter with variable block. Then all of a sudden off to the races here with a wide complex tachycardia. And then this is the termination of that tachycardia. Again, showing that back into this 2-to-1, 3-to-1 typical flutter. So thankfully, we were able to get some catheter in so we can really study this wide complex rhythm. This is her during her wide complex rhythm. So for those of you that haven't spent a lot of time in the EP lab looking at EGMs, this is kind of our mapping catheter that's been sitting, is kind of a half circle sitting in the atrium and kind of mapping these atrial signals as they come down. This is our typical lead here, and then this is our RV mapping lead here. So as you can kind of see, we see an initial depolarization up here in the atrium, and then that falls along down into the ventricle. So, either here we're having, a long RP sort of retrograde P wave that comes up, or more likely we're having a atrial depolarization that then leads to this, with seeing this wide complex rhythm up here. So this is the other example of it when this initiates. Again, we kind of see these atrial depolarizations kind of marching out, and as this initially is narrow, we see this continuing to march out at kind of the same rate. But all of a sudden, instead of having these 2-to-1, as you can kind of see, there's 2-to-1 here. This instead has one atrial depolarization to each ventricular depolarization, kind of showing and illustrating to us that instead of having some ventricular arrhythmia, at least this wide complex tachycardia that we're seeing in the lab is much more consistent with either atrial tachycardia or atrial flutter with 1-to-1 conduction that becomes aberrant when she speeds up. So we don't want to just take the word for it. So instead, we'll also, this happened in the lab where you can see down here, these are the RV leads, and then you could kind of see this large spikes, which is actually indicative of pacing. So this is her native arrhythmia right here, and then they come on to pacing. And actually, what you can see here, which is really nice, it starts that narrow, similar QRS, and as it speeds up, you can kind of see it widening. So this is kind of indicative of that when she becomes faster, she begins to aberrate instead. So once again, consistent that there is aberrant conduction in her ventricular pathway. So that all of this, what we're seeing, and now most likely what happened at the outside emergency room, is she now has kind of lower bundle conduction disease, which she didn't have when she was younger, because we know she used to speed up all the way to the 180s, maybe even faster, that just wasn't captured previously, and that this is not likely a ventricular tachycardia, and more likely atrial flutter or atrial tachycardia with 1-to-1 conduction. And then something I want to point out. So this was after all of this. She was kind of going in and out of something separate. So things that I want to point out about this is, if you can kind of see here, you can kind of see this P wave morphology kind of clearly changes, upright in AVR versus negative in AVR. And, it's our high rate lead. So we would expect it to be going away from us. And now we can see something coming towards that AVR lead. So that switches kind of the vector of the P wave, which kind of signals to us that there is an abnormal P wave. So if we remember, this is her kind of presenting EKG, and this is kind of a negative P wave deflection, kind of showing that this is likely her aberrant atrial tachycardia that we're seeing here, which is actually consistent. I'm not going to go all the way back, consistent with what she came into the lab with. So notably, this was her EP report. So patient was in atrial conduction. I won't read the entire thing, but just kind of these highlighted sections here. Patient was in atrial tachycardia with 2-to-1 conduction with intermittently going to 1-to-1 conduction with right bundle branch block aberrancy. And then unfortunately after this, after significant ablation, so going back and looking at the study in depth, she underwent 64 different ablations. So they came on to an ablation in the catheter 64 times and burned 64 separate areas. But despite this, it remained inducible with isoprel effusion. So there was a concern that this was going to continue to happen. And then down here, this is what kind of the plan was. We will attempt to treat with sotalol therapy. If there is recurrence, we will require mapping the left atrium, where the right inferior pulmonary vein could be the trigger. So this is kind of what happened. So after 64 different separate ablations, including a CTI line and different atrial tachycardia ablations, she remained despite that. So because of all this, because of all these arrhythmias, all these things going on in an otherwise healthy 46-year-old woman with apparently a relatively normal echo other than a newly reduced EF in the setting of more frequent arrhythmias, she underwent a cardiac MRI. So I'll play this a couple times for you. So that's her MRI there. I think these were the two best cuts I can show on that one. And here is the other. So again, this was a new thing for me. Obviously, the title of this presentation kind of gives it away initially. But if you can see here, once again, just looking at the right side, when in systole, this RA is huge with a very low tricuspid valve and a very small RV. And then during systole as well, or you can see this mitral valve should extend all the way to the LV. Here's another picture. I think this second one right there, you can see it the best. I'll kind of pause it again. Boom. So you could see kind of the extension of this going past the LV. So this then, there was notable for this, but I'll just read here. There's two things. The right ventricular appears atrialized and suggestive of Epstein's anomaly. The right RV is mildly dilated with normal systolic function, and the RA is moderate to severely dilated. And then here is our kind of key that brought me into this case, and this is what I'm talking about today. Mitral annular disjunction, 7 millimeters anteriorly and 6 millimeters posteriorly. The anterior mitral leaflet is myxomatous with mild prolapse. There's mild mitral regurgitation. So notably, right off the bat, this is kind of quite a shock that came to our EP team as well as to our general cardiology team, given that the fact that she had no history of structural heart disease, rather just only a history of these different atrial arrhythmias. So let's talk. I'm not going to talk a lot about Epstein's anomaly. That's kind of not the focus of this talk and could be an entire talk in and of itself. But as we, are all commonly aware, this is a disease, a congenital disease of childhood, and that nowadays, modernly, since 2000, the majority of patients are diagnosed in infancy and childhood with a median age diagnosis of 4.8 months. So a lot of these children can be diagnosed even in utero, but often will be diagnosed within the first year of life. But something that I thought was interesting when I was reading more about Epstein's anomaly, specifically in newly diagnosed adolescents and adults, that the majority of these patients, which I think was around 42%, so not quite half, but of those who were diagnosed with new Epstein's when they were above the years of 12, the most common presentation was actually an atrial arrhythmia. So the things that we always remember, just to go over it, is that these kind of three hallmarks: the displacement of hinge points of the septal and posterior inferior leaflets into the right ventricle, making the towards the apex, with the RVOT is the hallmark finding of Epstein. So kind of this displacement down and away into the RVOT of the tricuspid valve. Because of this displacement, we frequently have what we call an atrialized right ventricle because of the downward displacement and the functional orifice. So it's kind of much smaller, much more trabeculi, often associated with reduced RV function. And then because of that sort of pulling of the endocardium during creation and during the embryologic stages, it's often associated with shunts. So many different shunts that are associated with it, most commonly in ASD, but can also have PFOs, VSDs, and PDAs kind of all over the map with that, most commonly associated with ASDs. So that's kind of a comment on her Epstein's, but now really going to drill down and focus on what we're here for, which is mitral annular disjunction. So the main characteristic of mitral annular disjunction is an anomalous attachment of the posterior leaflet of the mitral valve directly onto the left atrial wall. So instead of kind of posting into the mitral annulus lower at the level, the top level of the the LV, excuse me, we are seeing it directly into the left atrial wall with separation between that mitral valve attachment and the atrium mitral valve junction. So it's higher up directly into the atrium rather than where it's supposed to be. So in one study, that generally just looked back at all these people and had echoes and had readers overread the echoes, specifically looking for different types of mitral valve disease, one of which was mitral annular disjunction. They found that there was a prevalence of up to 8% in the general population going around undiagnosed with mitral annular disjunction. Notably, though, these were all patients that received a TTE for some evaluation, so that is kind of an enriched population. But overall, we don't think of the mitral annular disjunction being very common, but this shows almost 1 in 10 people have this going around undiagnosed. So let's talk about it a little more and kind of show what we're seeing here. You see this echo. This is our normal insertion of the mitral valve. And instead, we can kind of see this mitral annular disjunction. We can kind of see it coming along the posterior wall and where it directly kind of inserts into the left atrium rather than down here in the apparatus on top of the LV. So this space here, this mitral annular disjunction, is what we call that space, which, if we remember on her MRI, they were commenting on 7 anteriorly, 8 posteriorly. So that kind of is an important signal on what we think about. And I'll kind of talk about risk factors moving forward. So once again, this is the anomalous attachment. So when the LV during systole with contraction, we see this pull down, which I'll show in a little more depth, of the mitral annulus, which is known as curling. So we can kind of see our mitral annulus dip down and pull in, being pulled in by that LV myocardium, and you'll kind of see it, what we call curl into the LV. So one of the best views is sagittal views, seeing this in especially in our cardiac MRs, which allow us to have a really good clear view. I like this box summary. This is from a review this Saba et al. Review that kind of went through the diagnostic criteria and the epidemiology of the mitral annular disjunction. So transthoracic echocardiogram, first line, which makes sense, and then second cardiac MR is really the gold standard of diagnosis. One thing that's important is we need a dynamic evaluation through the entire cardiac cycle. So even if you saw this kind of on a still frame echo, that would not be enough to diagnose this. And then repeating echoes over the years may be interesting to explore the development. So it's not just a sort of congenital thing that we think about. It can also kind of progress over the years. So this is, I just wanted to put a picture of a cardiac MRI over this, so we can kind of see the insertion above into the left atrium, with once again seeing this clear space between the normal insertion site and the sort of atrial ventricular level, excuse me, where our annulus usually sits, and instead this is an anomalous insertion here. So what are other signals and kind of other things that we can think about that if we're not sure, if, it doesn't look classic, I don't see a clear systolic curling, I don't see a clear insertion point, this can be a helpful sign, which we call the Pickelhaube sign. So I'll kind of bring up, that's based off of a German hat, which is this hat right here with this kind of spike. So I always think about, World War I, Kaiser Wilhelm sort of thing, with this kind of spike here. And this is the tissue Doppler. So this is the posterior leaflet tissue Doppler that we place on here. And that makes sense, right? If we're having this systolic curling with this pull in the LV, we're going to see a lot of movement with that tissue Doppler. So you see it kind of during systole, you see this rapid spike with high velocities in the tissue Doppler with return to normal. So anything that causes that increased systolic sort of tissue Doppler can cause this. So while mitral annular disjunction does have this characteristic finding, it can also be seen in bicuspid mitral valve prolapse and myxomatous mitral valve disease. So notably, she also had, our patient, just kind of calling back to our initial case, had myxomatous mitral valve disease, but you can see this in bicuspid mitral valve prolapse alone. So while it is sensitive for our MAD, it's not necessarily specific for MAD alone. Just knowing that if you see this kind of sign, that you should raise your index of suspicion for mitral valve disease. And also, this kind of wasn't talked about in the guidelines, which we'll get into in a second, but it can be associated with higher risk of malignant arrhythmias. Just this sign alone, and the kind of increased tissue velocity is kind of indicative that it all runs together in saying that there are higher degrees of arrhythmia. So kind of bringing it back to our patient, so that first we talked about. So if you remember, our mitral valve was actually called normal during her initial evaluation with an echocardiogram. And it's kind of hard to see, but when we can kind of really more clearly think about it, we kind of see the mitral valve, the anterior leaflet, and here we have this, our posterior leaflet kind of coming and inserting up here, which is likely, this is probably the level of that initial annulus, our normal annulus, and instead we're seeing it all the way up here. So instead, what diagnosed it is with her MRI. So here you can kind of clearly see that there is this significant area, or significant length, excuse me, between the insertion and the LV myocardium. So this here was what we're talking about with that 7 millimeters of separation. And if we remember going back, especially in the MRI, you could see that being pulled down during systole and having that characteristic systolic curling. So thinking about associations, because I'm talking about this in the setting of arrhythmias, right? But first talking about other structural associations. So something that I thought about, we often associate this with mitral valve prolapse, but it's only in 14 to 34% of cases, depending on which study you're looking at. So it's not, 100% of patients with MAD also have mitral valve prolapse, and not all patients, even a smaller proportion of patients with mitral valve prolapse, have MAD. So knowing that while this is associated, up to 2/3, even more, up to, 1 in 8 patients with mitral valve prolapse will actually have MAD. The other 7 will not. And then it's also very associated with this Barlow's disease, which I wasn't familiar with, which was a degenerative mitral valve disease characterized by this myxomatous thickening, billowing, and prolapse of the leaflets. So what this is associated with is significant MR. So often we see that myxomatous degeneration of the mitral valve disease leading to such significant MR that this almost always progresses to the point where the patient will need a mitral valve replacement, whereas MAD alone and mitral valve prolapse often won't lead to mitral valve replacement by themselves. And then it is associated with, which will lead me to my next point, but a distinctive entity from arrhythmic mitral valve prolapse. So then talking about mitral annular disjunction and arrhythmias. So this was kind of a central paper right here, this Disjunction et al. Paper. This was back in 2018 in JACC. So notably, this isn't a paper from the 1980s, right? This is actually a relatively recent paper that's trying to really pull out whether or not these patients are high risk for any sort of ventricular arrhythmias. So after this paper, there was a kind of a review of 19 separate observational studies, with 5 of the 19 specifically mentioning and showing an association of MAD with ventricular arrhythmias. Now, I talked a lot about atrial arrhythmias in my case, right? So I even went through a whole thing to prove that she didn't have ventricular arrhythmias. So thinking about this in terms of atrial arrhythmias, there wasn't a lot of data on it, actually. There wasn't a lot of studies that specifically mentioned it and specifically mentioned the risk of MAD with atrial arrhythmias as compared to the general population. But what I do know is those that reported it showed that it was relatively high. So in one study showing that there was a 21% incidence of atrial arrhythmias, and then in one showing there was a 29% incidence of this. So this was kind of showing that there is a high degree of atrial arrhythmias in this. Up to 1/4 of the patients will have atrial arrhythmias, but didn't really break it down by characteristics or anything that's high risk for atrial arrhythmias, rather more focusing on the ventricular side. So in one study, patients with an ICD, so this is patients that already had an ICD for a separate reason and also had mitral valve prolapse, were reviewed, and 100% of the patients that actually had unexplained VF ended up having underlying MAD, while only 12% of the patients that had no VF in this one study had underlying MAD. So showing that there was a significant increase in patients with VF and if you had MAD. So notably in this study, this was not done for MAD. This is just patients with mitral prolapse and ICDs kind of retroactively looking at that. And then in one case series that was not included in any of these reviews, but was a case series of people with cardiac evaluation undergoing autopsy for unexplained sudden cardiac death. 5 of the 32 patients had undiagnosed MAD. So 16%, like I said, we have different studies that show in the general population up to 8% having this. So there is an increased association, an increased prevalence in our patients with sudden cardiac death having this undiagnosed mitral annular disjunction. What I like is this kind of central figure here. This was one of the most important takeaways coming out of that paper, which kind of spun off all these reviews and all the research that is now still ongoing, is that these are 116 patients that had mitral annular disjunction. They actually followed these patients. So this was a prospective study rather than most of these other ones, which were observational retrospective studies. So they followed 116 patients with MAD, and then 14 of them had an aborted cardiac arrest or sustained ventricular arrhythmia. So they kind of broke this down into all of these 116 patients. This was just the initial evaluation, especially during the hospitalization, an index hospitalization for these patients. 14 within the index hospitalization already had a ventricular arrhythmia, but bringing them down into the patients with and without mitral prolapse. Obviously, like I said, 14 to 34%, so 90 with mitral valve prolapse, already a very high amount that we don't really see in the general population. So something to kind of be aware of in this study. But the 90 with this went on to not have VAs, no ventricular arrhythmias here. 93% not having this, whereas only 7% already had a ventricular arrhythmia in follow-up, whereas comparing this to the 26 without mitral valve prolapse, the prevalence was up to 31%. So this significant increase in VT and VF in these patients. So notably saying that if you have mitral annular disjunction, you're already at a higher risk for having a ventricular arrhythmia. And then if you have mitral annular disjunction without mitral valve prolapse, that raises your risk even higher. So kind of what do we do about that, right? If you have someone with mitral annular disjunction, how do you think about that? The risk is higher than the general population, but still, we're seeing kind of risk all over the map and not anything really clear. So how do we think about that clinically? So they've come out now with kind of looking at these different studies, trying to figure out what we think about as the clinical significance and what we try to stratify into high risk or low risk phenotypes. So the interesting thing, which I think is the first point right here, is in the benign category is isolated mitral annular disjunction not associated with mitral valve prolapse. And what I thought was so interesting was the central figure in the study before basically said the opposite. But in these study reviews that have since come out, these 19 reviews, even though most of them are retrospective, most of them have actually shown that having mitral valve prolapse is a higher risk phenotype, whereas in that initial study, it didn't. So otherwise, things that make you lower risk. So limited mitral annular disjunction. So what we think of as less than 8 millimeters, and one scallop involved, out of P1 through P3. Whereas here on the other side, if you have an extension over 8 millimeters. So remembering that our patient in the MRI we saw earlier was a 7 millimeter, so would characterize as benign. And one scallop. So if you remember, we had a disjunction anteriorly and posteriorly. So she had over 2 scallops. So we think of that kind of in a mix. She's in a mixed bag there with her specifically. Then we talk about association with curling and myocardial fibrosis. Our patient did not have fibrosis and did have systolic curling. And then last, no history of unexplained syncope and history of unexplained syncope. So what we think of as in our general population when we're worried about high risk arrhythmias, just do they have a history of that unexplained syncope or even known ventricular arrhythmias? So I really like this. I used this paper a lot in kind of thinking about how we manage these patients. So it's an EHRA expert consensus on arrhythmic mitral valve prolapse and mitral annular disjunction. It was done by the ESC Council, and it was kind of endorsed by Heart Rhythm Society, Asia Pacific Heart Rhythm Society, and Latin American Heart Rhythm Society. So it's an expert consensus statement that was kind of joined on with by a lot of different groups, including the Heart Rhythm Society. So in this, we think about high-risk phenotypes. So this is all of our mitral valve prolapse. So first of all, remembering that if we're separating MAD out and MVP out already, that was something that we thought of were risk protectors in and of themselves, but this is with all patients with mitral prolapse. So, and like they said, if they have this is already considered a higher risk group if they have that mitral valve prolapse. So throughout this, I'll kind of go to this other predictors. This was seen in that 19 study review, that age, low EF, mitral valve prolapse, late gadolinium enhancement, and the anterior papillary muscle were predictors. So all of these make sense, right? We already talked about the mitral valve prolapse, but if you're older, you have a low EF, and you have LGE and a PAP muscle, all of those would independently raise your risk of ventricular arrhythmias. So it makes sense that they do in the setting of MAD as well. And then last, what we talked about up here in this box, any large-scale disjunction was also predictive of NSVT. So didn't have enough people in that specific study to say that it was associated with VT. The event rates were too low, but at least showing that it was very predictive of NSVT with a specificity of 83%. So kind of back to this sort of decision-making table. I won't go through all of it. As you can see, it's kind of a lot of different areas, but in patients without VT, so if they already have VT, we're already down a different pathway here, but already thinking about our kind of higher risk features. So this talks about EKG features, including T-wave inversions, which we saw in our patient, as well as multiple polymorphic PVCs, which we did not. Mitral annular disjunction here so that's kind of what we're focusing on, but this with MVP would raise your risk, enlarged LA, echo characteristics, etc. Notable for all this leads to is what type of monitor you'll receive. So just because if you had every single high-risk phenotypical feature and mitral valve prolapse, if you do not have a history of VT, you still aren't just going to get a prophylactic or preventative ICD. You're just going to we're just separating you into which degree of suspicion and how we're going to monitor you moving forward. So thinking about management now, if we're kind of separating it out, okay, I have someone with high-risk phenotypes. I'm worried they've had one unexplained syncopal event in the past. How do I think about managing these patients? So first, I wanted to kind of look and see in our guidelines, what do we talk about? Do we talk about this as a high-risk phenotype, and what should we do about it? So this is I looked through the HRS EHRA expert consensus on ventricular arrhythmias. And one thing I want to say was this was the only place I saw it. So looking in the entire article, there's one table that says that this sort of thought, a mid-systolic click, systolic murmur, marfanoid body habitus, mitral valve prolapse, and this is how you treat it. There was no mention of mitral annular disjunction, and no, there was no mention of just prophylactically implanting these people with ICDs. So I thought that was something notable. That's the only place it shows up in our expert consensus from the American side, from the HRS side. So this, going back over here on the right side, is instead that initial expert consensus that I was talking about earlier. This is the talking about sudden cardiac death prevention. So documented history of VF, non-tolerated VT, and the absence of reversible causes. Yeah, that makes sense, right? That's essentially a indication for ICDs anywhere without mitral valve prolapse. It's a secondary prevention. Here again, LVEF 35% and heart failure. Yeah, that's already an indication regardless of mitral valve prolapse. But these are the ones I wanted to talk about here. So I think of this, their kind of heart system is green heart is, I would consider class 1, and yellow heart is considered class 2. They don't break them down into A or B. But this is what I think it is here. In patients with arrhythmogenic mitral valve prolapse, high-risk feature, and 2 or more phenotypic risk features, an ICD may be reasonable. So this is what I think is interesting. This is people without defined ventricular arrhythmias. thinking about, should we prophylactically do primary prevention? So high risk feature, sustained VT, NSVT, unexplained syncope. That makes clinical sense, right? If they've had sustained VT or have things that we are concerned for VT events, then we should already be thinking about it. Then talking about phenotypic features, T-wave inversions and inferior leads, talking about that previous sort of decision tree on our previous slide. MAD phenotype. So this is kind of what we're thinking about with our patient here. The clear MAD phenotype, breaking that down into a high risk MAD phenotype can be even more helpful. And then other echo findings: enlarged left atrium, EF less than 30 to 50%, excuse me, and late gadolinium enhancement. So all of these things can kind of lead us. So if you have all of these high risk features, then a ICD may be reasonable. So thinking there's not a lot of strong things here, not a lot of strong recommendations for our clinical management. So before I kind of close up, I do want to say that throughout all of this, I've been talking about how there's really not a lot of studies, 19 sort of retrospective studies, 1 prospective study. What I thought was important was this study here, which was titled "Are We All Mad?" kind of talking about how we're thinking and being more aggressive with patients with mitral annular disjunction, and wanted to take a look and take a step back. So one thing that I thought was interesting, they're talking about it as, we clearly have this mitral annular disjunction, right? But when does it become mitral annular disjunction? It's a spectrum. Does it become a mitral annular disjunction when it's 2 millimeters above the LV insertion? Is it 6 millimeters? Where is that? So they looked at different studies, these studies here, many of which were included in the review I previously mentioned. And what they wanted to look at was, who are the people that they're looking at? If you already have mitral valve prolapse, you've raised your risk of having separate things. So if you have a mitral valve prolapse, you're higher at risk for having mitral annular disjunction, higher risk for having atrial arrhythmias. So we're already enriching our own population. So it's hard to separate out if these people, it's primarily because of the MAD or it's because of all other things. Then if we're basing it, if CMR is our gold standard, we have a lot of people that are based on this alone. So if you're saying 8% of the general population has MAD because we saw it on this one observational study, well, we already talked about how often it's either missed or mischaracterized on echo. And then right here, which I think was their most important part, which I think is the biggest takeaway, is what is the MAD extent? So in these studies right here, when did they classify it as mitral annular disjunction? And once again, these criteria are all over the map, right? So the lowest one being 3. And this is our prospective study from 2018. So look at that threshold, 3 millimeters, and you already are diagnosed with that. Whereas in some studies, it's up to 8. So in this one study in 2021, they don't consider you having mitral annular disjunction till you already have a separation that's already in the high risk phenotype. So that'll change our prevalence, that'll change our incidence, all these things to say, really where we define the initiation of mitral annular disjunction will affect what we see in these studies. So that is one thing that I thought was interesting. They also noted that one study has shown MVP to be a predictor, while another it's been shown to be a negative predictor, talking about kind of what we brought up earlier. And then in a review of 12 studies, a separate one, only one study found a statistically significant connection to sudden cardiac death. So 11 other studies showed no increased ventricular arrhythmias. And one thing to note through all of the things that I've been talking about now, notable to really recognize that the event rate is low. So our atrial arrhythmias, we're talking up to a quarter of patients have atrial arrhythmias. However, our event rates for ventricular arrhythmias, are in the 8%, 12% changing. And that Disjunction et al. Paper was kind of with that incidence in the 30% was kind of the highest incidence we saw of any ventricular arrhythmias. And if you remember, that was in a group of roughly 30 patients with MAD alone. So already what we're seeing is a low risk phenotype from the rest of our studies now already has almost a third of patients with VT. And then, so I think that's an important thing, that we're trying to figure this out from retrospective studies with, 30 people, 100 people, and trying to define event rates that are even lower than that. So then we kind of turn back to our patient, right? We've shown in the EP lab that it's likely an aberrant conduction. She hasn't had any syncope, but has had significant lightheadedness, pre-syncope. So we had a discussion. So Dr. Bhatia and Dr. Lloyd on the EP team and Dr. Bott on the heart failure team. It was decided that we did not think she had ever had a wide complex rhythm, and instead we will keep the life vest that she was already had from her outside hospital, and like I said, start on that sotalol medication after her arrhythmias, and then go from there. So unfortunately, she did come back. So she was discharged on sotalol and low-dose GDMT to help improve her ejection fraction. Was discharged home to Savannah to follow up with her EP there. But unfortunately presented to the ED again and was found out to be in wide complex tachycardia again into the 170s. Notably, no shock from her life vest. This was lower than the kind of the threshold of the shocking. And thankfully, this self-terminated again without any shock. So did not need to be cardioverted in the emergency room this time. So transferred back to us in the setting. So we had a long discussion with her and her family. Here's her transfer EKG. So seeing again, we can kind of see these flutter waves here. So either atrial tachycardia or 3-to-1 flutter. Even despite, this looks typical, and she already had a CTI line ablation. So, we think of very high success rates with atrial flutter ablations, but she already presents back in atrial flutter despite an ablation and despite sotalol. So while this rate is slow, during her stay with us, she would frequently climb up into the 150s, 160s, and was very symptomatic from that. So after a long discussion, she underwent AV nodal ablation and placement of a CRT-D. So notice we could have placed a CRT-P alone and not had the minor increase in risk from the placement of defibrillator, but it was decided that if she were to undergo placement of device, just to make it a defibrillator, given that, this history of wide complex tachycardia, even though we are fairly certain that this was all in the setting of aberrancy. So kind of coming back to our teaching points here, thinking about the characteristic findings, MAD is characterized by anomalous attachment of the posterior leaflet of the mitral valve directly onto that left atrial wall and separation between the attachment and the atrium mitral valve junction. And then thinking about characteristic phenotypes that make us higher index of suspicion for ventricular arrhythmias. There's no large prospective studies confirming a link between MAD and ventricular arrhythmias, but a pooled collection of smaller studies have shown a strong link with these as possible factors. Remember that old age, low EF, MVP, and late gadolinium enhancement, things that we already are worried about with ventricular arrhythmias in this patient population, but also this large MAD distance seems to be a pretty strong predictor of both atrial and ventricular arrhythmias moving forward. And then lastly, I talked about a lot of expert consensus statements, but there's no official guidelines, and there's also no randomized controlled trials and treatment. But in patients with unexplained syncope, concern for ventricular arrhythmias, you should keep a strong suspicion for MAD on TTE and consider whether or not someone would deserve a ICD based on high-risk phenotypes with that history. Here are my references, and with that being said, I'm happy to take any questions.
Thank you so much, John. That was a really interesting review of a topic I think a lot of us don't know about. I was curious in your conversation with, EP on this patient, like how often is EP going up, doing the MRI and looking for this particular thing?
I don't think it's generally in our sort of discussion. I think when we were doing the MRI, we weren't really thinking about, is there some sort of structural, what we really wanted to do was use that to kind of rule out any myocardial scar, using that as sort of an indicator of an area that could be concerning for VT. They basically wanted to prove to themselves they felt comfortable not giving an ICD prophylactically, but this was completely unexpected, the Epstein's and the MAD.
So, very interesting. Any other questions?
Hey, John. Steve Clements. John.
Yes, sir.
So don't you think this is an echo diagnosis first?
I think it is. So that's kind of what all of the places, most of the expert consensus statements would say would be the first line is diagnosing it based on echocardiogram. And there was no place that said you should get a cardiac MRI if this is diagnosed, anything like that. But I think the MRI is kind of the gold standard of diagnostic criteria. But I completely agree that it's it can be an echo diagnosis alone.
Yeah, so we have, the criteria for the MRI fine, but I'm not sure, did you find anywhere in the echo literature that showed some criteria? But, I've noticed this for a long time, probably didn't even recognize it, but, you saw our patient that I'm not sure we were doing the MRI for the right reason, but we came out with the answer. So interestingly, that EKG you showed in V2 showed up and down QRSs, which are called splintered QRSs or fragmented QRSs. And those QRSs are described in Epstein's anomaly, which your patient had, which and Epstein's has a myriad of arrhythmias in itself, which you all got into. And so your patient had the mitral annular disjunction, but put Epstein's with it, and gee whiz, you got all kinds of arrhythmias. So that was a very interesting situation.
Yeah, completely agree. I think in a different version of this talk, I could just talk about her in the setting of her Epstein's alone. That could be the talk in and of itself. That's probably, after discussion, we are more likely concerned that that's where her atrial arrhythmias are coming from, and the MAD was just kind of an incidental finding. Yeah, totally agree with you, Dr. Clemens.
And John, this is Olson Billen on Clemens Station. Fantastic review. Quick question. Is there a role for an EP study for those with unexplained syncope and normal halters?
Just in general or in this population?
In this population?
They didn't. I would say probably, depending on your index of suspicion, but I know that EPs in general are usually hesitant to undergo EP studies without a specific, reason or finding previously. I don't know if having a higher risk phenotype, something like mitral annular disjunction, would push them more into doing an EP study. There's no place in the literature on the expert guidelines not guidelines, but experts consensus that says perform an EP study. So it's not really in that clinical pathway that expert consensus would state, but I think it might be reasonable in someone with that, especially if you're going to implant, a 30-year-old with an ICD, it might be reasonable to try to provoke it beforehand.
Gotcha. And one more question. Did you come across with any papers that looked into appropriate ICD therapies in those with higher risk features and got a prophylactic ICD? Are they being shocked?
So I didn't see any that specifically had an ICD for MAD. I did that one study that I kind of brought up that looked retrospectively at patients that had an ICD and mitral annular disjunction. So they weren't placed for mitral annular disjunction, but it kind of was a retrospective study saying, hey, if we pull out all these patients with MAD, what do we find? And they did have a higher incidence of appropriate therapies in that group. So it's kind of hard to say, who knows, it didn't break it down, or it probably did in a supplemental appendix that I didn't read, that I didn't see, of why they initially got implanted. But it did show that even compared to the same group in the patients without MAD, there was a higher risk of appropriate ventricular therapies in that group.
Thank you. Nice job again.
Thank you.
Hey, John, it's Peter Block. Quick question about the mitral valve versus the atrium in this one. I reviewed a paper for, I don't remember whom, I think Jack, but whatever, about a year ago, about whether or not doing something to the mitral valve would change the possibility of the rhythm developing, or an arrhythmia developing. You didn't mention anything about doing something to the mitral valve, for example, clipping it or something. Is there any evidence that doing something to the mitral valve so that it doesn't, quote unquote, pull on the atrium, whatever that means, makes a difference?
Yeah, that's a great question. I'm not sure if there's more of that specifically in the prolapse literature, but I will say across my survey of all mitral annular disjunction data, I didn't see any specific mention, nor was it in that consensus statement of considering any sort of mitral valve therapies. plate replacement, clipping, any of that. I didn't see anywhere where that mentioned either considering that in patient with ventricular arrhythmias, or whether or not they had any data to say that those folks that had that went on to have less incidence of ventricular arrhythmias. So that's an excellent question, but I didn't identify any data that showed that.
Hey, John, this is Kunal. Great job. As the primary attending on this young woman, it was a very difficult situation, as you remember. And not only did we discover she had new Epstein's, but she also had this mitral annular disjunction. She'd had all these arrhythmias and presyncopal episodes. So it's a very complicated situation. And I was very, very thankful to the EP team to help us out with this. And I think, I guess my only thought going forward is if I ever find this in somebody who's symptomatic, I think my go-to is to get EP to help me make this decision, because it seems still very complicated with a lot of nuances. But thanks, you did a great job. Very thorough review.
Yeah, I appreciate that. It's very hard. Like I said, even in these expert consensus statements, it's always well, there could be higher risk, but maybe ICD would be reasonable. And you're like, it's not an entirely helpful, informative decision when you say it might be reasonable.
Right, especially committing a young person to a defibrillator.
Yeah, absolutely. I just wanted to kind of read these questions briefly from the chat. Shannon Walker said, data yet? Curious if there's any data to have found genetic markers to identify more high-risk patients. Also curious if for most patients presenting with MAD, if it's indicated to get a CMR for risk stratification. I think the first one with genetic markers, I didn't see any genetic markers kind of mentioned in any of this data. I think thinking about arrhythmogenic mitral valve prolapse, I think there are some studies out there that there could be sort of genetic phenotypes of that, but I think that's why they specifically kind of separated it out these to two different clinical entities that are associated with each other but separate, because I don't think, or there might not even be any genetic studies, or if there are, they've likely been negative because they weren't kind of included in any of the data that I looked at. And then just like Dr. Clemens was saying, in terms of cardiac MRI, I don't think it's necessary, but it is kind of be helpful, especially if you feel like you don't get a real sense in different views of that sort of separation. Like in our echo in our patient, you couldn't kind of clearly define that distance, whereas in cardiac MRIs, you could almost clearly define, how many scallops are involved, what is the sort of the distance of disjunction, which can help kind of stratify that. But I think at this point, we don't currently have, you're not going to implant someone because they have, a distance of 8.5 and not if they're 6.5. So I don't know if there's a lot of clinical difference there.
Okay, thanks, John.
Yep. And then last but not least was Will saying, have you mentioned this, but is MAD considered congenital or acquired? So that is an excellent question that a lot of these papers seem to specifically stray away from mentioning. There were multiple papers that discussed following MAD over time to see whether or not that distance increases. But from the sense that I get, the insertion point is likely congenital, and that distance over time with growth of the atrium, dilation, all those things can grow. But the actual insertion point, I believe, is congenital and not acquired. All right, if that's all the questions, kind of thanks everyone for listening in.
The preceding program is copyrighted by Emory University.